Hello, Dr. Manjunath, can you hear us?
Yeah.
Good afternoon.
Good afternoon, Dr. Sushil and Dr. Srinivas Kumar and all the panel. So we are actually doing a case of valve in valve, and we have with me Dr. B.C. Srinivas and Dr. K. Srinivas, and we have the entire team. So we have to take, of course,
First slide, please.
we'll just go ahead and present the history.
So this was a 72-year-old male who had actually rheumatic aortic stenosis with severe AR and underwent a AVR with a Carpenter Edward bioprosthesis 25 millimeter. This was in March 2008. And since 1 year, that valve has degenerated and he has come back with symptoms now, which is class 3 at present. He has clinically aortic stenosis. Next slide. So echo showed the eccentric LVH with a degenerated aortic bioprosthesis with a gradient of 109/61 and grade 1 to 2 leakage, aortic regurg. It was a rheumatic process actually for initially. So he has mild mitral valve disease with mild MR. TR is grade 1. The ejection fraction is normal. Next. So this is, and we have evaluated this valve with CT, and you can see that the interesting aspect of this, it was a predominant aortic regurgitation valve replacement done, and then that bioprosthesis has degenerated. So if you look at the area derived, it is actually the CT derived is around 22.7. LVOT is very roomy, 29. And you look at the STJ, it is 36.7. And coronaries are quite decent. We have LCA 14.3, and then RCA is almost 18 plus. The aortic sinuses are very roomy. You can see 36, 37, 38. And the sinus height is also quite adequate, almost 13.4 millimeters. Next. So you can see this. The thing is, though this is a 25 millimeter valve, when we evaluated with CT, you look at the CT derived dimensions. If you look at the average is coming as 22.8. LVOT is quite, as I mentioned earlier, it is 29 on average. Next. So you can see here the internal dimension of the prosthesis. When we looked at CT, it is coming close to 20 millimeters, and outer dimensions is coming to around area derived is around 24. So on an average about 24.6. So though the surgical note says it is a 25 millimeter valve, 25 millimeter Edward valve, the internal the dimension is 23 millimeter. If we look at the app. Next. So you can look at the sinuses are quite roomy. You can see here, and the coronary is not a major issue in this case. In fact, valve anchoring will be a major issue because it's still, if you look at the processes which has been used, we feel that it is smaller for the actual annulus he had. Next. So the next. The ascending aorta is quite okay. Next. So this is the deployment angle by CT. So it's LFO 14/6 caudal. Okay. So
Judkins coding.
So next. So you can see the anatomy because it was a eccentric left ventricular hypertrophy in the past because of the predominant AR. You can see that there is left ventricle still. There is an eccentric LVH, as you can see in this. Next. So if we choose a valve of if you look at the VTC, VTC is going to be adequate in this case, both for the right as well as the left coronary artery. Next. So we have looked at various sizes. In fact, 24, 23, 24.5, and 26. So you can see all these three valves. Actually, the VTC is going to be good. So then next. Go to the next. So the femorals are quite adequate. So the least dimension we are getting is 6.3 in the external iliac. Otherwise, it's quite okay. Mildly calcified femoral arteries. So this is the case which we are doing. So any thoughts from the being a valve in valve, we have gone with a
Sentinel is in place.
Sentinel is in place. So the regarding the procedure wise, so if you look at this valve, we definitely need to fracture this valve. So balloon, being Carpenter Edward, I think it is amenable for balloon fracture with a high pressure balloon. So we have the Atlas Gold ready, balloon fracture, and then follow it up with a my valve implantation. So we have chosen the 23 as a now. Okay, with a 2 to 3 cc extra. That's what the plan is. Okay, we are using the octocar my valve. So the
Dr. Sushil, actually, being a valve in valve, the concerns are, one is PPH, patient prosthetic mismatch. That is one, and the second is coronary obstruction. So here the sinuses are quite pretty roomy. That is one, and also coronary height left is almost 13.
Yeah,
14.3.
Yeah.
So this is a Edwards Carpentier valve. The true, and obviously the leaflets are inside the studs. So the gradients are pretty high.
You're right. So, I mean, I guess the question here in terms of, the key questions, as you said, are the coronaries are not as much of an issue. The main issues in valve and valve are the hemodynamics and preventing patient prosthesis mismatch. The Edwards, the CE valves, I just kind of look with, I mean, these are single wire design. And so more so than fracture, they often remodel. I think in terms of choosing valve size,
This is
the true ID for this is like a 21, right?
GR.
And so, if you fracture or you expand, can you get to is there a way you can get to with my valve, you have intermediate sizing, right? So would it be possible to, put a 24, put an intermediate 24.5 my valve, and then expand it with a 24 true balloon after?
That's correct. We are planning 24 only.
23 actually. 23. We had planned 23 actually.
Sir, Anantaraman here, Anant here. Nice
Yeah,
case,
Anant.
sir. And a lot of discussions can happen around this.
Yeah.
First, it's a valve in valve. I think whether we should fracture or not, that's the second question. Now, the valve choice for this, you can use both balloon and self, because both of them will give a good result without much patient process mismatch, depending on the body surface area. I think we have the luxury of the local valve, which is intermediate size, 24.5, 26, other things. If we didn't have it, then probably we'll end up using a 26 S3. But here we can use a 24.5 and then go up with the balloon 24 or even whatever it is higher. Or a self-expanding 29, I may not fracture it. If I put a 29 in this, I don't even think about fracturing, because that will give you enough orifice and that will give you the best result. Because all the parameters fits well for a 26 evolute. But since we are using here a 24.5 my valve octocore, there's no harm in just putting a balloon and modifying. Even if you're not fracturing, you will modify it.
Yeah, I think that's an important point. But I do think, there's some advantages. We have these discussions all the time, and the conversation of lifetime management comes up.
Yes.
So this is a younger patient. If you do a balloon expandable, again, I don't know what the goal is. Maybe you get 7-8 years from this, and then you have an easy platform to put a self-expanding after. Where if you do a self-expanding now, maybe the hemodynamics are a little bit better now, but the second option becomes more complicated. So I think there are options for both and trade-offs. The issue, as the team here highlighted, in terms of balloon fracture, it does come with risk, and you have to sort of be careful, look at the anatomy. Here, the LVOT is big, so there's room for expansion. The sinuses are big, the coronaries, there's room. So I think it's a good case for, whether you
are trying to cross this valve with the AL2, and we tried with Judkins and also with multipurpose. We are just
these are the most painful cases. This and some of these bicuspid cases are really challenging.
Yeah.
So the thing is, the CT showed internal dimension of 20. So do you still feel that, so we thought going by that to fracture with a 22 millimeter atlas, and then, okay, then use a 23 with 2 TC extra.
So I think that's reasonable. I guess the question is, do you think it's
Yeah.
a 25
We
valve?
are
Because
there,
sometimes
we will
these,
exchange
one of the
for
things
this
is the
and
op
then,
notes
yeah.
are
Yeah.
may not always
Tegitin nanu.
reflect,
We will just take a
J-
exchange then JY, please.
Yeah, we have crossed.
So there was a lot of difficulty in crossing this, as you could see, because the iota was, the dilated. You can see the pigtail behind the process is how much roomy it is. So
Yeah.
to get into that, the degenerative process orifice was a difficult thing.
Yeah,
So
these are the very difficult ones, sir. Sometimes you need to
Actually.
keep changing the view. Sometimes you overlap the two posts and just isolate it and then try it. As we were discussing, the CT showed the diameter, actual external diameter of the valve stent is 25.
ತಗೊಂಡು ಹೋಗಿ, ಆಮೇಲೆ we will use the pigtail catheter.
Hello, why can't you give a JY? Okay.
If you have a second, would it be possible to see the slides and just show the CT?
No, we have to
measurements
take the
again?
pigtail.
Yeah, but show the slides again, the CT. Show the slides. Yeah, go back, please.
Oh, no. Again, I think it's, maybe go back a few slides.
Yeah, wait, go forward. Go forward,
So
wait,
here,
no, go back. Yeah, wait there. See the internal dimension here, the average is 19.8. That was our worry, though. The surgical notes says it is a, 20.
Mamuli J, why can't you
can
give?
you, can you go back one more measurement?
One more measurement back, one more slide back.
Yeah. So I mean, I think you're right. It probably is a 25, the valve frame, and all
Yeah,
these
so-
labels, all
so
these
that-
labels are based on the manufacturer.
So I thought actually by looking at the CT, I thought let me be a bit more conservative, take a 23 instead of a 24.5. Panel can suggest that.
So
And patient also in addition has got moderate AR?
Yeah, it is
Yeah.
got
So
here.
I think 23 is very reasonable here as well. I mean, I think
Yeah.
23.
these are the
We'll
ones
take
where we
pigtail.
we
23.
don't know.
Yeah, and what should be the strategy, Sushil? Should we pre-dilate and then deploy, or should we just deploy the valve and pre-dilate? Because there is no clear-cut guideline with respect to, the whether we should modify it.
So I'll give my
Upfront.
opinion, and I think I'm in the minority. And I'm in the minority in the US as well. I tend to fracture pre. Because I'm worried about the impact on the transcatheter valve leaflets with the high pressure inflation post.
Okay.
Be careful.
But I will say I'm in the minority because the concern with that is that you damage the leaflet, you get AR, you avulse the leaflet, and all of those potential risks. I think here you could do either because if you're gonna, and I think you're right, there is no guidance.
Yes.
I'm gonna ask down the panel, when people fracture, just real quick, go one word, pre or post.
Okay, fine.
One vote for pre,
I would go direct and postulate.
one post.
Pre.
Pre. Post, or 50-50, I'm pre.
So what is the majority opinion, Dr. Sushil?
Pre is the majority.
Or
Okay.
post or pre?
Okay, so there were 3 that were for pre and 4 that were for post. Shows you how split it is here. So I think it's whatever you prefer and most comfortable. I think that's the important thing. I think if you're gonna do it pre, you have to have an experienced team that's ready to put the valve in quickly, because if you get AR,
Okay,
you gotta go in
Yeah.
quickly. So it's whatever you're
So
comfortable
we're
with. There's no
going
right
to-
answer.
okay.
The LV pressures are.
What is the majority? Of course, not in the auditorium, I am asking. Overall, what is the overall opinion as far as valve in valve, whether it should be pre-dilated
You
and
can, cameraman, you can show
or
the
whether it
gradients.
can be post-dilated?
Can you show the gradients? So we have the LV pressure 184, the aortic pressure is 124, it's about 190 and 120, so 70 gradient, right?
No, it's a very impressive gradient. Well, I mean, it was 4 votes for post and 3 votes for pre. So a slight majority for post. I mean, do you think the angle of the aorta is such
We'll go
that you'll
with
have
the
difficulty crossing or anything? Do you,
Or
if you,
safari wire.
Safari.
do you
Safari,
worry
please.
about the ability to cross the aorta?
I don't think there is a difficulty in crossing the aorta here because it's quite roomy. The dimensions are close to 4 centimeters.
We'll just show the sentinel. Can we just move?
So the sentinel is in place
So
actually.
yeah, this is the sentinel. Okay.
This was a very tortuous. Can you go to the first floor? We'll show them the in the meantime. See what happened was this was a tortuous subclavian and the innominate. So you can see here, no, before that, show that injection. So you see that how tortuous the innominate and there was a double 90-degree
Yeah,
curve.
2 loops.
So we had to what we did here is we put a wire from the femoral into the subclavian, straightened out that, go next, and then took the sentinel device from the right radial artery and deployed it. So next. So just to make sure that the king. So there was some difficulty in negotiating the device and the wire through that anatomy. So we are going ahead with the safari wire now.
Come back to, okay, fine. Okay. So now the decision
Is the valve ready?
dilate. Okay, Srinivas?
Okay, we will pre-dilate, sir. We will pre-dilate this with a Atlas gold and fracture it because the reason is this is an eccentric LV. As you can see, this is a remodeled LV which had accommodated the severe AR in the past. So that way we have that luxury in this particular case. That's why actually I asked that question
Keep doing.
whether we should really pre-dilate or post-dilate. But we can fracture this valve and then deploy the the
So
valve.
going with the Atlas balloon now.
We'll go with 22 millimeter Atlas gold, fracture this, and then we'll go in with a
The only
after
issue
core.
with the 22, you won't be able to remodel too much.
Okay.
because- But I think, open up the leaflets, but it won't really remodel the frame.
Yeah, I fully agree with your statement. We would, if we go with pre-dilatation, we probably need a bit larger balloon.
Balloon, Atlas.
Vijay,
22. So it is decided to pre-dilate with 22 Atlas.
one more syringe.
And any cover is there on this? Gold.
Yes.
I'll
one
hold
more.
the wire, okay?
I personally believe there will be a huge need to perform post-dilatation. Yeah, that's clear.
Okay. Is the valve ready?
I think if you balloon with the 22, you can always
Just
post
hold.
later, but that's where the challenge of which size my valve.
Cross ಆಯ್ತು. I think pacing, everything is okay?
Yes, sir. Yeah.
You have checked?
Yes, sir.
Just one second, I'll just hold this.
One minute.
Okay.
I think for people who are not familiar with the octocore, which is the indigenous myval, the octocore has got 2 layers, not 3 layers, only 2 layers of cells. It does have a depth marker and it does have a commissure tab. So you can have good
One
sort of
minute, you
commissure
just
alignment. with octocore.
Aspirate.
Just push it a bit.
And it's a fantastic valve and stability wise, it's very good. That's the improvised version of the.
You just push this. Air out.
Air out too.
Okay.
Will
Ready?
inflate to 23 or 22? 22. Okay.
So what we will do? Okay, go forward a bit more, sir. Go forward a bit. Okay, that's fine. Okay, that's fine.
Is your valve loaded and ready to go in case there's a?
Yeah, valve is loaded, ready to go. Yeah, it is, Sushil.
Did
Yeah,
you
we're
test-
going to inflate this now.
Did you test rapid pacing?
Wait. First, we will inject with the seed. Okay. Pacing on. Okay.
Contrast is less.
Okay, you go. Go.
No,
Did you-
deflate.
Deflate. Deflate. Okay.
Your pacer's still on. Your pacer's still on.
Pace is off, please.
Okay.
Okay.
The contrast is too diluted.
Pressure is a bit down.
Okay.
So
Okay.
I think contrast was too less, so that's the reason we could not see the.
It's okay. Pressures are fine now.
I think contrast has to be. I think dilution is very less. Okay, then I have to pull out the balloon back.
It's
Once
okay.
enough.
We will what?
Either
The-
way, the frame didn't really expand, right? Because we didn't see it hit the frame.
Yes. Frame did not expand.
I think we have to properly dilute. Okay, otherwise we'll know what is.
We will.
I mean, the only question is, is it worth considering a 24 and a half?
One second.
Okay. The
No, so I
directly.
think now that we pre-dilated, the hemodynamics, everything stable, we could go with the 24.5 octocarb,
Okay.
put it,
Okay.
and then we'll see the hemodynamics and then
Yeah.
decide
Okay.
on the balloon
One second,
size for
Srinivas.
fracture.
What you do? Give 24.5.
Keep doing fluoro.
Because.
So we'll go
change
with-
to 24.5. Change to 24.5. No.
Fluoro.
See, we will prepare 24.5 and deploy because anyway the patient is stable.
I think let there be a proper dilution. Otherwise, okay.
If you do the 24.5, the options after would be to post dilate then with the 24, because then you would get the remodeling and stretch and
Yeah.
Okay.
expand fully as well.
So we are going to take 24.5.
I think that's very reasonable.
Yeah, that sounds good. And keep ready a 24 Atlas Gold after that. Yeah.
Anantaram, there is a issue with 24 gold. We have the length of the balloon is short, 75 centimeter. It won't reach. That's one issue we have here right now. 24 gold.
What other balloon you have, sir?
The
Atlas.
right now.
Because
The
True is
new-
not available
new-
in India.
No, True is not there. This is the only one, but unfortunately, this is available in 75 centimeter shaft length. Only up to 22, they have up to 120 centimeter length, shaft length.
I don't
Hello,
think that's a big
Let us check
issue
the contrast.
because I have fractured it quite late.
Hello,
I have
Let us
put a
check the
valve.
contrast.
I have
Okay,
put the valve, accepted the
Okay.
hemodynamics, and then
Okay.
fractured even after 4 to 6 weeks. I have done that, or even after
Okay.
6 months, I fractured it. So if you get a good
Okay.
hemodynamics, you can always bring back and fracture it once the balloon is available.
Okay.
If they need it.
okay. That-
Anyway, after deploying the valve, I think it's correct to, we'll see whether there's what is the resting gradient.
So if you're preparing the valve, Dr. Sangadvilu asked us to come back just for a couple of minutes. to
Sure,
show the final
sure.
result. Is that okay?
Yes, yes.
Sure.
Yeah, you can go and
we
come
can
back.
go and-
Okay, we're back with you now.
Now we are preparing the valve.
Yeah, we are preparing the valve. It will
24
take
point
about
5.
2-3 minutes.
Okay, no worries.
So because initially we are planning to have a 23 valve, now it is decided for 24.5. So we are recrimping that.
This highlights a lot of the challenges and all the unknowns with valve and valve. We're this many years out and we're still struggling. And I think if you did the 23, it wouldn't be wrong. If you did the 24.5, it's not wrong. I think
Just to
there are choices. The only reason the 24.5, I think we were thinking on the panel is because if we want to
Have you seen the
post-dilate.
dimensional alignment?
result.
3 o'clock. Okay.
I think
Say,
it's Dr.
Sushil, we
Srinivas.
wanted to
Ye-
know, suppose if coronary is an issue, the crossability is better with a balloon expanding compared to self-expanding, no?
So yes, I think management of coronary obstruction is going to be easier if you choose a balloon expandable in these scenarios. It's just because you can go around it, above it, you can protect easier with a guide liner. I think all those issues are easier with the balloon expandable.
And even in cases if you have really low difference to the coronary ostium, you could make left main or right coronary protection with guide liner and standing position just in case.
Definitely, I think
yes,
if you are planning for one more sort of transcatheter procedure for this patient, then definitely the balloon expandable valve now is a better option so that the next valve can be a self-expanded inside that.
Can I ask a question? I don't have experience with this valve. How is the foreshortening characteristics here, and where do you position this valve?
No, the foreshortening is more or less similar to the original my valve from the LV towards the aorta.
Ready?
It has got two layers of cells. It's got the depth marker and it's got the commissural tab alignment as well. You could work out the commissural alignment based on the CT, and about 70%, I would say 70-80%, it does align. And
It has to be.
otherwise,
the annulus.
coronary access,
So it has to
because the
just
top
to
cell, only
below.
2 rows, the top cell
The
is
lower
nice and
portion
open. So
matches well. That is a
So
good point.
This surgical valve is tall. It's 21 millimeters, right? So how tall is a 24 and a
Couple of studs
my
should
valve?
be below the.
It's about 19 millimeters. It's about 19 to 20 millimeters. And this actually, what we have done now while loading, the actually 3 o'clock position was, clock position was actually aligning well with the right coronary artery. So that the commissural alignment we have taken care of in this case. And actually there are, observational studies wherein, in fact, we are part of those, a couple of studies wherein we have looked at the after car with based on CT. We do align the commissures, and in this case, it was corresponding with a 3 o'clock. So 85% of the times it will align. That is the observation.
Show the Ryan, please. Okay. Anyway, we exit. Okay, fine.
So this is the 24.5 after core.
Okay. 1 second. Okay, okay. 24.5. Okay.
Okay, come back.
I
Yes,
think that's okay.
That's a good position.
Foreshortening is not much.
Okay.
I think we'll have a picture.
Pigtail, we will.
Okay.
We'll look at it.
Ready?
Actually, we could, if you look at the valve, the surgical valve, actually it has been implanted a bit lower than usual. So here we have an opportunity to come back a bit.
I think this should be okay.
But you're landing it in the frame of the surgical. That might be too high there, no?
Yeah, that's
Or-
too high.
no, I think the original position was good, sir.
Yeah, this is good. This is good.
Yeah, because there is not much foreshortening, but still there is
Yeah.
foreshortening. So about 20%, 30%, whatever. So you will
I
get a
think
good
now it's
alignment if
about
you slot it there.
75-25.
Okay.
It looks good, but very slow deployment under
One
pacing,
second.
very slow deployment so that you can control it still.
Okay. That's enough, I think.
Yeah.
This is a good
Yeah.
position. We are good to go here.
So, ready?
Wait. Facing on this.
Yeah, pressure.
Take it now.
I think no, picture is in.
Because
Very
the strength of the.
I think position looks okay.
Facing.
Yeah,
On.
Seems to come up a little.
position is not bad.
Okay.
Just go
It's on
ahead.
the outer curves, they'll make it go.
Okay.
Very gently, very slowly.
Okay. Go up. Go up. Gentle, gentle, gentle. Go up.
Yeah, now we can go fast.
Go up. Hold.
Go up, go up.
Up.
go to nominal pressure.
Full.
Full.
Okay.
Okay. Facing off.
Okay. Fine.
Okay.
Okay. Pressures are up.
You can replay that. You can replay that.
Diastolic is 85 to 90.
ಯಾವ್ದು ಫುಲ್ ತಗೊಂಡ್ ಬಂತು
Full save ಆಗಲಿ.
ಅಲ್ಲ ಸೇವ್ ಆಗಿಲ್ವಾ
ಅಲ್ಲ, inflated ಆಯ್ತು.
ಬಂದಿದೆ
Okay, it has come back. Okay, let us take it.
so we'll take one second Srinivas, this I will remove one second say I'm removing this
So you see-
Injection, please.
Yeah, the stent
you
post
just hold
where,
this
15.
Yeah.
ಅಲ್ಲ ಒಂಚೂರು ಇದ್ ಮಾಡಿ ಅದು ತೆಗೀರಿ ಅದು
so the question
Banta?
here is, do you do the
ಬಂತ ತೆಗೀರಿ
24?
ಅದು
Oh, we don't have the 24 balloon.
okay yeah ಬಂತ okay fine
Okay,
But the inflow will be modified.
okay.
see, we'll do one picture
Yes, one moment. Inject.
nothing no significant tear if at all trivial is because of the wire
That's great. So, I think, the initial
Yeah,
plan had been with the
With the same.
24 Atlas, but
Still we will
not
use the
available
post-
right now.
So what we will do, Sushil, we will use the same mammoth here and try to post dilate a bit with an 1 cc extra.
ಹಿಂಗ್ ಇಟ್ಕೊಳ್ಳಿ ಇದು we'll remove
Maybe check the gradients first, yeah? I mean,
Yeah.
with a slightly undersized balloon, I'd be concerned that it's just an unnecessary.
yeah we'll check the gradient yeah just fluoro
One moment.
I'm removing hold it
Leave it. Leave it. It's not good.
ಮಾಡ್ತೀರಾ okay be careful
Okay.
okay so then we'll exchange for pigtail okay so we'll check the gradient I think acceptable gradient is what 10 or 15
Yeah, I mean, ideally,
Let-
you get 10.
Yeah.
Especially for a male, and especially on the table, because it will always be a little bit higher after. I think the point earlier, if the Atlas becomes available, you can always bring back and re-expand. I think is important.
yeah pigtail so we're just checking the gradient now and PR interval is okay there is no QRS widening
It is in sinus.
So, but I think for the audience, the slow inflation is an important thing in all TAVRs, but especially in valve and valve. Because a lot of times what happens, especially when you have a difficult to cross valve,
ನೋಡಿದ್ರಾ?
you're always on the outer curve and you have a lot of forward pressure. I always, in those type of scenarios, make sure the last movement I have is just to release. I think you saw before they deployed, they pulled back a little bit, so it was not on the outer curve. Because if you do it and you cross onto the
Okay.
outer curve and then just inflate,
ಸ್ವಲ್ಪ aspirate.
the valve will move even more ventricular. Even here, even though they pulled back, still had a hard time. The
Oh,
valve
no
was-
gradient.
They ended up a lot, pulling up quite a bit. So,
Saku.
I think that's important to sort of understand that, and slow inflation allows that.
Sushil, we have this pressure tracing for you. You can see here, no gradient.
Yeah, the gradients look great. I mean, you have a gradient of like 4, it looks 8, 4,
Yeah, 4, yeah.
maybe
And
it goes 7, yeah.
Sir, I think this is the time to stop because it looks beautiful. No gradient, fantastic air index. This patient will do very well.
Anant Ramal.
And
Dr. Anant?
yeah,
Hello, Dr. Manjunath here.
Yes, yes.
That's a great statement. We have to stop it
Stop.
here. Okay.
No, I think knowing when to stop it is an important skill that we all have to learn sometimes. So I agree. Dr. Manjunath, it was an honor and a pleasure to have you and your team with us. It was a great
Yeah,
case
Dr.
example.
Srinivas, yes, he's
Yeah.
here.
Dr. Srinivas, Dr. Manjunath, and everyone on your
Yeah.
team. It's an honor for us and it's a great case. You highlighted a lot of teaching points and there's a lot of learning and the back and forth discussion. And so I think Srinivas wants to say a few
Yeah.
words because we're going to end this session, but
Yeah, Dr.
excellent
Srinivas Kumar.
case.
Yeah, thank you,
Nice,
Dr.
talking to
Manjunath
you.
sir and
Sorry, I could not
Srinivas.
make it.
A
I had to
great
stay
help
back.
always ever since we started TCT. In spite of his all busy schedules and various commitments, is always there, sir, with us. Thank you again, sir, for showing an excellent demonstration of this Indian valve, again, in a difficult scenario of valve in valve. It's also important when to stop also. Sir,
Yeah,
you
thank you
want to
very
say that statement which you make, the treatment should not cause more harm than the disease. Anyway, thank you. Thank you very much for a great demonstration, sir. A round of applause for Dr. Manjunath and his team.
Okay.
And
Thank you.
Thank
thank you, sir.